I'd like to welcome you all to the Vein and Lymphatic University Grand Rounds today. I'm Tom Wakefield, Professor Emeritus at the University of Michigan. And today the topic is related to can we ablate the saphenous vein when we have chronic iliofemoral outflow obstruction? We have a presenter today. This is KJ Nagarsheth. He's Program Director of the Vascular Programs at the University of Maryland, soon to be the chief at St. Louis University. Our two discussants are Windsor Ting, Professor of Surgery at the Icahn School of Medicine at Mount Sinai, serves as an attending surgery at the Mount Sinai Hospital. Windsor, a good friend, has many leadership roles in the American Venous Forum. The second discussant was going to be Glenn Jacobowitz, but Glenn had a family emergency. So we've been fortunate that Dr. Jose Almeida has agreed to be the second discussant. Jose is the voluntary professor of surgery in the Division of Vascular and Endovascular Surgery at the University of Miami Miller School of Medicine. He's the founder of the Miami Vein and International Vein Congress, and he's also one of the architects of the venous portion of the VEITH meeting every November. So we have a very interesting topic to discuss, and I'm going to ask KJ to give his presentation, and then we'll have our discussions. Thank you. KJ, go ahead.
Thank you, sir. Thanks for the introduction. So today's topic was when is it okay to ablate the truncal leg veins with chronic iliofemoral outflow obstruction? To be fair, there's not a ton of literature on this, so I had to kind of pick and choose what we used. But today the objectives are going to be going through clinical context and disease mechanisms, some supporting evidence for combined treatments, procedural strategies and technical considerations, some clinical algorithms based on what I found in the literature, and patient selection, and then some concluding thoughts. So clinical context and disease mechanisms. So venous leg ulcers and chronic venous disease, they represent advanced chronic venous disease driven by either superficial reflux or proximal venous outflow obstruction. The role of the outflow obstruction, it often causes persistent venous hypertension down the limb, impairing venous ulcer healing despite treatment of superficial veins. The challenges for treatment, endovascular laser ablation alone can fail in the presence of these iliac lesions and can delay healing or promote recurrence. When you're looking at the comprehensive evaluation of these patients, you're trying to optimize your outcomes. It requires identifying both treatable superficial disease as well as deep venous disease in the pelvis and in the groin area for durable healing. So the pathophysiology of this, iliac vein stenosis or obstruction leads to a sustained elevated venous pressure throughout the leg, and that can be worse during walking as well. It can worsen venous insufficiency down the truncal veins as well over time. Compression by arteries or narrow vertebral areas can impede the lumen over 50%, causing this elevated pressure down the leg, something that we see in iliac vein compression. You get persistent hypertension, which leads to an inflammation, endothelial dysfunction, and poor oxygen diffusion, which all ultimately impairs wound healing down the limb. And duplex ultrasound of the limb itself could sometimes miss an obstruction in the pelvis. So cross-sectional imaging or venography are really helpful and I think essential in identifying and detecting these iliac lesions. So in terms of procedural strategies, improved ulcer healing, there have been several studies that have shown that when you have axial and truncal veins that are a problem, you want to treat those as well as the deep venous system by adding iliac vein stenting or opening up the iliac system. In addition to endothermal treatments such as radiofrequency ablation or laser ablation, this significantly improves wound healing and the wounds stay healed at 12 months compared to EVLA alone. Iliac stent placement is an independent protective factor for ulcer healing by correcting the proximal outflow obstruction. Risk factors for refractory ulcers includes obesity and prolonged standing. This can sometimes complicate outflow or complicate outcomes, especially if you have an outflow obstruction. And venous ulcers often require treatment of both the superficial and proximal obstructions for durable healing. Regarding recurrences, single stage iliac stenting, in addition to ablation of the lower extremity veins, has been shown to have significant decrease in recurrence and fewer need for reinterventions over time. So, as opposed to a staged approach, if you use balloon angioplasty alone for the iliac lesion, we've known that there is a high recurrence rate of restenosis in 90% of cases. A single stage treatment of both the deep and superficial has also been shown to improve venous clinical severity scores and quality of life scores for these patients. And it provides a more durable long-term outcome and better success rate overall, reducing the need for overall reduced number of procedures for these patients. So in terms of strategy and technical considerations, the advantage of one stage treatment corrects outflow obstruction promptly, reduces venous hypertension, and enhances ulcer healing. There have been a number of studies that showed faster wound healing, increased symptom relief, and reduced recurrence, as well as better quality of life. The two-stage operation can be better for younger patients with mild disease, but typically does result in delayed wound healing and a higher need for further interventions in these patients. It all depends on the distribution of their disease, though. If they have a isolated refluxing vein around an ulcer, treating that refluxing vein alone could be enough with good wound care and compression to help these patients. So it really comes down to, is this the first ulcer for the patient? Is this a refractory ulcer? Is this something they've had multiple times? That's when you want to investigate further. But as we mentioned earlier, balloon angioplasty alone of the deep system is usually not durable. Regarding technical considerations, it's really about patient selection, understanding the wound, making sure that all infections are treated, making sure that edema is controlled, making sure that you have sharp debridement of these patients on a regular basis for the wounds to help them heal faster, and make sure infection is also treated very well. If you are going to treat the iliac segment as well, typically following standard stent guidelines and recommendations, picking the right size stent, pre-treating the lesion before you stent them with a balloon angioplasty and then stenting them, using intravascular ultrasound to have proper positioning to make sure you don't miss any proximal disease in the common femoral, or you don't miss any distal disease at the IVC confluence is very important. And you really want to make sure you have full stent apposition to the wall as well as full stent expansion if you're going to treat them. Precision is very important for these things to make sure that you have good stent patency and reduce the venous hypertension down the leg, as well as enhancing treatment of these ulcers with local wound care and good follow-up. So some algorithms, early identification of the venous obstruction. So if you have people that have very edematous legs throughout, if they have wounds that are extremely weeping and you can't find a superficial source alone that can explain the whole leg, looking at the deep system early is a good idea, either with some sort of ultrasonography if they're of a good body habitus, or cross-sectional imaging or venography. Standard catheter-based venography is very helpful in these patients. If they have an isolated saphenous system or a perforating vein that is causing problems, treating that in a low-risk patient is a good idea. And then you can do a staged approach in that fashion. But if it's a recurrent ulcer or someone that has other comorbid conditions like morbid obesity or something like that, doing it all as a single stage usually works better for these patients as opposed to a staged treatment. Indications for stent are very similar to what we all know. You really don't want to stent people from mild iliac stenosis. The mild iliac stenosis, subthreshold under 50-60% is really not going to cause significant venous hypertension down the leg. So stenting them is not going to give you much benefit in these patients. But people that are post-thrombotic, that have chronic occlusions, they're the ones that are going to get the most benefit from stenting. Younger patients, especially those that are planning pregnancies or having other physiologic events, it's probably worthwhile to have a very informed discussion with those patients before going forward with stenting. And this is not something that should be done for cosmesis, right? This is not something just because the legs look like they have a lot of varicose veins or reticular veins or anything like that. This is not a cosmetic thing we're talking about. We're talking about doing this for more advanced ulcer and to prevent further ulcers from happening. So with that, just a few concluding thoughts. Venous ulcers and recurrence reflect combined reflux and outflow obstruction. Superficial ablation alone is sometimes inefficient for patients with recurrent disease as well as very severe ulceration. Treating iliac stenosis restores venous hemodynamics, and it's really critical for these ulcers to heal properly. A one stage has been shown to help these patients at a higher rate and prevent recurrences compared to a staged approach in the appropriately selected patient. And so one stage is usually preferred if possible. Durable outcomes really depend on patient selection, stent sizing and positioning, and correct sequence in the procedure. And with that, I'm happy to take any questions. Thank you.
KJ, that was great and very clear. Thank you. Before I ask for the discussions from Windsor and Jose, just one question. What about C3 and C4 patients? Not those who have not had ulcers yet or don't have a current ulcer. What's your
Yeah, so
approach?
so for C3 and C4 patients, I mean, I personally I look at where their distribution of symptoms are. Is it at the foot and ankle level, or is it above? Is it in the thigh and buttock and hip area? I don't think iliac stenting is going to help a lot if you have isolated foot, ankle swelling and pain. May help some, but I don't think it's going to help a ton, especially if they don't have a post thrombotic issue.
Okay, very good. Windsor, shall we start your discussion?
Sure. Thank you. KJ, thank you for a very interesting presentation. I think this is a very interesting question. Is it safe to close the saphenous vein or other varicose veins in the setting of someone with chronic venous obstruction like May Thurner? Even though it is a very interesting question, as you alluded to in your presentation, we don't have any data. And I look quickly. I didn't see any publication that specifically addressed this question. Is it safe to put a stent? Is it safe to do a varicose veins when someone has May Thurner? I think part of the reason is that it's very difficult to know when you do something with varicose veins. It's hard to know whether that person has May Thurner. Yes, you can do MRI, you can do CT, venogram, but we know those imaging are not 100% accurate. So it's a very difficult question to answer. I look back in the patient I've stented. Clearly, there is a subset of patients who have had varicose veins in the past. So I think they coexist in a subset of patients. And I think my answer to that question is that yes, it is safe to ablate the saphenous vein in a setting of someone with a central venous obstruction. I given this question a little further thinking is like, what are the patients with varicose veins that make us think they may have a central venous obstruction? There are several group of patients I can think of. One group is someone with pretty severe venous symptoms, but pretty mild superficial venous disease. And we see these patients every now and then. Another group of patients to suspect a central venous obstruction is someone with persistent venous-like symptoms, even after we done a successful ablation of their superficial veins. And we see these patients as well. I think some patients with atypical varicose veins, for example, varicose veins located more on the lateral thigh, maybe in the posterior thigh region, I think it is not strict for superficial venous disease. These patients probably has something else going on in the pelvis or in the abdomen. And the last group of patient I can think of is patient with recurrent varicose veins. I can think of a few patients, very severe varicose veins, I treated them, ablate them successfully. They come back, sometimes just a few months with recurrent varicose veins. So these their clinical settings suggest there may be something else going on than just superficial venous disease. I think in these patients, it's worthwhile to do some further investigation whether they have a May-Thorner type pathology centrally. So I think it's safe to do both. But we don't really know the answer uh, at this time. Thank you.
Hey, Windsor, in your second group of the four that you just talked about, the one who has symptoms that come back after they've had superficial treatment, how long do you wait before you say, well, this is a failed procedure in a sense, and I need to look for something more?
Yeah, these are very, we see these patients, right? They come back and say, hey, doctor, you took care of my varicose veins. I don't see the varicose veins anymore, but my leg is still swollen. They still feel uncomfortable. So usually I make sure they have tried compression stocking. They try a period of conservative medical therapy. It may be 1 month, it may be 3 months. And then if they still symptomatic, I would do some cross-sectional imaging in these patients. So the period is variable, 1 month, sometimes a little longer, depending on the clinical situation.
Okay, very good. Jose, let's hear what you think.
Yes. Um, a lot to unpack what Windsor said. My approach is probably a little different with a superficial vein disease. Um, so let's just back up a little bit. There are some papers, some retrospective papers. The original one that we typically, or at least I quote a lot when I give this type of talk, is Raju, 90s, around 98, he had like 115 patients, a stripping group that he stripped a non-thrombotic and stripped a post-thrombotic group. And, they do a lot of APG in their office, physiologic tests, air plethysmography, and basically concluded that saphenous vein stripping was safe and APG improved in both groups, were they post-thrombotic or non-thrombotic. So that kind of carried forward that it's okay to do superficial vein procedures in post-thrombotic patients. Then Eric Peden out of Houston did a recent review in 22, systematic review. Of course, it's all retrospective studies, and a few of them were from the Roger Neglin group and some other Asian studies. And Alexander Pugioni, who had a good one in there that is widely quoted. But bottom line is, most of the time, if you've got a compelling reason to do a saphenous vein ablation in the face of post-thrombotic disease, it's usually safe. The only caveat that I would put there, if there's a large limb size discrepancy. So you almost know without any testing if there's symmetric size of the limbs, that there is outflow. And say you compare now in the same patient a post-thrombotic limb to a non-thrombotic limb, and the post-thrombotic limb, yeah, there's some disease, but it's not super engorged. So they have outflow. And then there's some folks, and these are usually post-stenting that has occluded, where now the iliofemoral outflow tract is completely occluded. They usually have the femoral vein down and the profunda diseased. You will get limb growth from outflow obstruction. So in these cases, you know that the collateral outflow is probably limited, and you'd really need a real compelling reason to do a saphenous vein ablation. And then you got to be careful with these, because if you stand them up, you may see saphenous reflux. But if you lay him down and you take the hydrostatic pressure away, is there outflow out of the saphenous vein in the supine or recumbent position? Meaning, like the other 12 hours a day when they're, sleeping or laying around, is there outflow out of that limb from the saphenous that is refluxing and standing. So, all that to say, it's usually safe. You do have to be careful, especially when the limb is large and you know that the outflow is impeded, which is not that common in non-stented patients, in my experience. They will usually develop adequate collateral outflow. But the stent occlusions, where there's no inflow and no outflow, these are the ones that you'd really have to be careful with.
So Jose, that sort of answers, but maybe you could just specifically address it. Anil just put in the chat, Anil Hingarani, is it safe to perform superficial procedures with a chronically occluded iliac vein?
So that's exactly my response. If the iliac vein is occluded and the limb size is relatively normal, there's adequate collateral outflow. And if you did a non-invasive test like a limb outflow test with APG, you'd probably see that there's some preservation of the ejection fraction of the calf from adequate collateral supply. But if the limb is very large from an occluded iliac, I would definitely focus on the outflow before doing a superficial vein procedure. If it's an ulcer patient and the saphenous vein is right in continuity with the ulcer, I mean, axial reflux of the saphenous with minimal varicosities in the calf, and that reflux going from groin to ankle right to the ulcer, those are going to be the ones that are most compelling for saphenous vein ablation, even in the face of an occlusion. But you do have to put, everything together. I would say that most of the time you do not need to stent iliac outflow when you're going to do a saphenous ablation, like almost all the time. Rarely do you need to stent them. But you do need to be careful and look at everything before you make all these decisions.
Jose,
Do
I
you
think that's a
Oh, go ahead, Windsor, please.
Jose, I think that's a great point. If you look at the patients who come to see us with varicose veins, clearly there's a group. Their problem is just varicose veins. And I think we should take care of varicose veins. To do anything more than varicose veins treatment is kind of not what they're looking for. But there is a small group of patients. Their varicose veins is just part of an overall picture. There's something going on beside the varicose veins. So in these patients, I think it's reasonable after you've taken care of the varicose veins, if they still have symptoms, to look further.
So Windsor, in
Yeah,
that
I
sort
would
of
say
patient,
to look for a specific symptom, which is venous claudication. I mean, that's really
okay.
the most predictive of stent success. For swelling, high-grade iliac vein stenosis and their C3, as Tom mentioned earlier, you're probably going to get a little improvement in the swelling, but not complete improvement. And you got to let the patient know that ahead of time that, this is not going to be a miracle cure for you. We might improve the swelling a little bit, but I don't think stents really are for swelling. And why do I say that? Because I used to put in stents for swelling 15 years ago, and for the majority of them, it did not work out well. The ones that really seem to benefit are either true venous claudicants, a bursting thigh with exertion, or a non-healed ulcer with iliac outflow disease.
KJ, do you have any comments to the discussants?
No, I mean, I agree with everything that Dr. Almeida and Dr. Ting have said. I think that you have to have a very comprehensive overview of these patients and their venous system before intervention. I think there has to be a strong indication. Indication has to be paramount, has to be king. And swelling alone is not, in my experience, has not been very successful in resolving with iliac intervention. The thigh claudication, the venous claudication, that definitely seems to improve. And if they have venous hypertension in the leg and have a recurrent ulcer, that also I will look for an iliac issue to address because we're trying to heal the wound.
Very good. So thank you all. There are two other questions in the chat I'll just mention here and get your responses. One is, what is your experience with the prior use of ultrasound catheters to predate the to predilate the stenotic venous site prior to stenting or venoplasty? Any experience with that?
Is that referring to intravascular lithotripsy with ultrasound? Like a lithotripsy
Didn't
balloon?
say. Didn't say.
That
Didn't
is.
say.
If they're asking whether you should pre-dilate prior to stenting, I'd say that's a yes. Number one, you're going to post-dilate anyways, but these nitinol stents, they will expand on their own just with heat. But my understanding is the nitinol lattice, you need to really set it with 1-to-1 balloon dilatation post. And if you don't pre-dilate some of these really tough fibrotic, they're going to be the post-stenotic ones more than anything. The fibrotic lesions, you want to pre-dilate them and break them before you put the stent, and then post-dilate also. I think that's what they were asking, but I'd say the standard of care is pre-dilate stent and then post-dilate 1-to-1 with a balloon.
Perfect.
High pressure
And the
balloon
other
like
question has to do with the patency. Is the patency of stents at 3 years, 2 to 3 years, the same if you have combined the procedure with a superficial vein ablation versus if you haven't? Patency at 2 to 3 years.
The only study I know of that is Neglin's study where he did them together, and I can't remember exactly how far he followed them out, but he got very acceptable results with doing ablation and stenting at the same time. That's really the only paper I'm aware of where they've done that. The answer to the question is whether they're non-thrombotic versus post-thrombotic. Of course, non-thrombotics are not going to have inflow issues. The stent patency at 10 years is probably around 98%, 99% in the literature. Post-thrombotics is a different story, probably around 70% at 5 years. And that really depends on the inflow more than anything. Of course, it's inflow, outflow, and conduit anticoagulation. But it seems that most people get adequate anticoagulation. The stents seem to work well if placed properly, and then it becomes an inflow issue, and that's a patient selection issue. Good inflow, good stent patency, bad inflow, bad stent patency.
Yes, very good. Thank you very much. Any last comments by anyone? If not, we're near the end of the hour, or half hour. I will mention that, first of all, thank you very much, KJ, for your presentation. Thank you, Windsor. Thank you, Jose, for your excellent discussions and for the questions that came in. Thank you. On April 29th, the next venous and lymphatic grand rounds, it's when to ablate a truncal vein after superficial venous thrombosis. And the presenter will be Dr. Bashira. And we'll have two discussants, Dr. Jindal and Dr. Mendoza. So that should be also a very interesting topic to discuss. So with that, I will close out and say thank you very much, and I wish you all a really good day, and thanks again.
Thank you.
Thank you.